Our next speaker is Mose Herne. Mose is a citizen of the Mohawk Nation, Turtle Clan. He grew up on the nation until enlisting in the U.S. Navy Nuclear Propulsion Training Program. After his military service, Herne completed his Bachelor of Science degree in psychology and neurobiology at Clarkson University. He then moved to Boston, Massachusetts, where he completed the Master's of Science degree program in Experimental Neuroscience at Brandeis University and the Master of Public Health program at the Boston University School of Public Health. Herne then completed the coursework and qualifying exams for the Doctor of Philosophy degree in Environmental Health Sciences, Behavioral Neurotoxicology. He is the Director of Planning, Evaluation, and Research at the Office of Public Health Support, Indian Health Service. Mose?
Thank you, and good afternoon, Sego. I want to thank you for inviting me to be here, but I do want to talk to whoever put me after Rosemary. All right. Wow, that was powerful. Um, so yeah, I grew up at Akwesasne, and growing up at Akwesasne is it's it was great. It was great for me. That cultural piece is so very important, and to be connected to that and to grow up, you know, uh, going to the longhouse, going to ceremonies, um, playing lacrosse players, any? No. Well, you should learn. um, Lacrosse is a sacred sport to our people, and it means much more than just a sport. In other ways, it also allowed us to travel to other reservations and interact with all our cousins throughout the Haudenosaunee Confederacy. So um, the reason I bring that up is that uh, there have been powerful stories today talking about culture and spirituality, and those are important. And I was exposed to those early, and they've pretty much carried me throughout my life. And I was telling my sister cousin Louise that I wish Ohologo was there when we were growing up. And but I think you said a very powerful thing when the young man said that that's also helping the men. So it's helping the young men, but it's helping the elders too. And I think that transgenerational connection is so key and so powerful. That just touched me really deeply when you brought that up. Um, I want to talk a little bit about being a veteran. I take the opportunity every chance I get to talk about how many how many Native veterans are out there. We serve in the armed forces in proportions greater than any other racial and ethnic group, and we have since the Revolutionary War. Just on my home reservation, which is maybe 12,000, there are over 300 veterans. So we all answer the call, and it goes back to that warrior culture, or that being a warrior, and that's a whole other talk unto itself. Being a warrior isn't, uh, being a fierce fighter. Being a warrior is being a good man. You know. Um, so I'll provide some links that actually talk to some of that. And when you have time, I would really recommend viewing some of the webinars that we've done. Um, sorry, I'm sorry I can't see very well up here. I don't know whether to put my glasses on or off. Um, the other thing I wanted to bring up is that environmental health, uh, I view it very broadly. A lot of folks just look at environmental health as, some determinant in the environment, some chemical, some toxicant impinging on, a biological system, and then there's some health effect. But I think we've heard today that that's not really the case, right? There's just not physical things that are exposed to us. Uh, we're constantly interacting with the environment, and it's not just physical. There's social, there's emotional, there's spiritual, there's economic, there's political, and it's all those environments that are interacting with us. And I think it's those interactions that manifest in health disparities, and not just at the individual level, but at the family level and the community level. So that's just kind of something to think about when people talk about the environment and effects of the environment. It's not just physical things that we're exposed to through our food or that we get on our skin and that affect us. It's our social environment. It's our built environment. It's whether or not we have buildings around us or communities around us that promote our health. And these are all things that we need to think about. And I think everybody's touched on that, and everybody's provided powerful stories on how we need to think about that. Um, so today we don't have a lot of time, or I don't have a lot of time. You've had all day, and it's been great, right? So I just want to give an overview of the Indian Health Service. I was invited here to talk about men's health. And again, my view on health and my view on men's health, or more broadly viewed male health, is one that's been informed by culture and sort of those holistic view of environment and interactions between individuals and families and communities. But I did want to give an overview of the Indian Health Service, what we do. I wanted to talk about disparities in health and wellness. Um, but a lot of times you you go to talks and they talk about disparities, and they just paint the doom and gloom. And I'm inspired by Chief Cook, and I think we agree that we need to do something about it. Um, there are these disparities out there, but we really need to do something about it. And sometimes it's just taking that first step and doing something, seeing if it works. If it works, great. If it doesn't, well, you still learned something. So trying to do something to ameliorate the health disparities, I think, and it empowers people. Sometimes when you sit and when I was in graduate school and you'd hear you'd look at all the data, you'd hear all the lectures on health disparities and where American Indians, Alaska Natives, were on that spectrum, and it was depressing. And I think just over the years, I've been thinking, well, we really need to identify something that we can do to empower folks. We've engaged in some pilot activities along those lines, and I also want to bring up a discussion, and then I'll pretty much wrap it up. So the Indian Health Service, the mission is to raise the physical, mental, social, and spiritual health of American Indians, Alaska Natives to the highest level. And instead of saying American Indians, Alaska Natives every time, I'm just going to say Natives. All right. So the goal of the IHS is to assure that comprehensive and culturally acceptable personal and public health services are available and accessible to Native people. And the foundation is the government-to-government trust relationship between the federal government and tribal nations. And there's that solemn obligation to promote healthy Native people, communities, and cultures, and to honor and protect the inherent sovereign rights of tribes. So the IHS works in partnership with tribes, and that partnership results in comprehensive health services. Um, but every tribe is different, and every tribe has different needs. So many of the tribes administer their own programs. For example, behavioral health, 55% of mental health funding goes directly to tribes to administer their programs, and over 85% goes directly to tribes to administer their programs. So I think that reflects an understanding that um, solutions uh, to challenges and health challenges in the community are best developed by the communities themselves. But the federal government works in partnership with tribes to try to come up with those solutions and to implement them and to promote health and well-being uh, among among the people. So one problem with that is that if we look at per capita health expenditures for a variety of federal healthcare providers, see the big bar on the left? That's Medicare funding. The next bar is national funding. The next is VA. The next is Medicaid. The next is a cost index. And the two little bars on the far right, right here, that's Indian Health Service funding. So Indian Health Service has the lowest per capita expenditure of all federal programs. So that's a challenge. The Indian healthcare system, as we call it, since it's comprised of both federal and tribal hospitals and clinics, um, is depicted on this slide. So there are 28 federal hospitals, 16 tribal hospitals, 61 health centers that are run by the federal government, and 235 tribal health centers. In Alaska, all the Alaska Native clinics are run by the communities, and health stations, the majority of those are run by tribal programs. So here's the doom and gloom. So disparities, well, first there's good news. So over the last 40 years, there has been a lot of reductions in health, uh, bad health, poor health. So mortality has been reduced for a number of causes, including tuberculosis, cervical cancer, infant mortality, homicide, stroke, unintentional injuries, motor vehicle fatalities, pneumonia, influenza, heart disease, alcohol-related deaths, and suicide. But the rates still remain high. And if we look at the disparities, the ones that are continuing here are alcohol-related death, tuberculosis, motor vehicle mortality, and diabetes. And for death due to unintentional injuries, and homicide, suicide, pneumonia, and influenza. It's still quite a big list. Now, if we look at age, the black bars are natives, and the gray bars are all races. So if we look at the younger ages, there's a higher rate of mortality among native people. So our younger people are dying at much higher rates. If we take a look at age-related mortality, but we break it down by gender, we see two curves. The top curve are males, and the dotted curve are females. So for alcohol-related mortality, we can see that males are dying at a much higher rate compared to native females. If we look at diabetes and heart disease, the native males on the far left are dying from diabetes among the 35 to 44-year age group at at twice the rate of native females and over 3 times the rate for U.S. all race males. And heart disease, again, much higher rates among native males. Suicide rates, um, especially among young native males, they're the highest rates. They're way up here. And these are compared to native females. We're also seeing increases in native female suicide mortality compared to non-native females. So although the disparity among native females is getting greater with respect to non-native females, the overall rates for native males are still much, much higher. Among the 15 to 24 and 25 to 34 age group, it's 3.5 times higher. So if we break this down by age categories, we can actually do comparisons with all race males. So that's just all males in the U.S. population, and also native females. And among all age groups, you can see that suicide mortality is much, much higher among native males. One of the things that we observed lately is that there's disparities in psychological well-being, and we can look at that by gender now. There's this thing called the National Health Interview Survey. So if you look at that, it's a survey that asks how many days in the past month have you, felt hopeless or felt worthless. And if you look at the graph, the native males and females are on the far left. Males are blue and females are, I would say, pink, but it's not really pink, right? Among all other racial groups, you see that females report more days of feeling hopeless and worthless in the last 30 days, but among native, the native group, the males are much, much higher than the females, which is different than any other racial category. And the native males, they're reporting these psychological distress basically for many more days per month. And then if you think about the suicide rate being sky high, there's obviously some psychological distress among our young native men. So, what do we do about it? Well, it's a tough question. Boy, this is tricky, isn't it? You're like, so what do we do about it? About 2 years ago, and how I got into men's health, I guess we have, like at the federal government, we have our primary job, right? But then we have all these other jobs that we have to do. It's called collateral duties or other duties as assigned. So I got one of those was a men's health meeting, and it was down in D.C. and the Men's Health Network brought together about 15 federal agencies and brought us all together to start talking about men's health. And initially, I just went. It was another committee meeting, and I just went down. And but the interest was overwhelming. And there weren't just men at the table or men serving institutions at the table. Like everybody was at the table. And we started talking about everything from marketing. I think one of the marketing campaigns was like, men are more than just a prostate. There are other things. They even had some really clever marketing campaigns out in out in the Midwest that was to get men to come in for prostate screenings because obviously we still need to have prostate screenings. They had pancake breakfast that they called pancakes and prostates. Well, like as Tom said, we like to eat, right? So we come in for the pancakes and we get a prostate cancer screening. Um, and there were just so many different ideas across the board. Uh, there was a guy that was specifically looking at male veterans, and he developed this entire curriculum. Armin, I can't remember his last name, but an entire curriculum to work with male vets, and there were just so many things going on. So as we were discussing this, and this was another collateral duty. I didn't have a huge mandate to jump into this, but being a native male, being a veteran, being around this sort of energy and this synergy, we thought, well, what can we do? Um, One of the things that seems to be out there is that there's not a lot of awareness. So one of the things that we thought about was, okay, well, how do we raise awareness of the issue? How do we get information out there? How do we just start the conversation? And we came up with a webinar series. Initially, it was the Substance Abuse and Mental Health Services Administration. It was Indian Health Service. It was the Office of Minority Health. It was Society of Public Health Educators. And notice I said everything out. I didn't throw a bunch of acronyms like alphabet soup. It was OMH, Samson. So we had a lot of momentum at first, and we had a first seminar, and we hosted it because we don't have a budget. We didn't have any money to do this, so we said, well, we'll do it. So we did the webinar, and over 120 participants got on the call. So I thought that was pretty good, and we just started going with it. So the first one, again, that was just us feds giving a background, giving the doom and gloom, and just raising awareness about the issue and try to bring some attention to it and recruit some folks to start the conversation. The second one, the theme was around building resilience, community, and culture. And we brought Brian Yazzie, and he's with the Boys and Girls Clubs of America. And he was great. He talked about all the different Boys and Girls Clubs throughout Indian country, and I didn't know there were that many. There are hundreds out there. When we were growing up, we had the youth center and maybe Johnson O'Malley summer camp in the summertime. But now there are like all these Boys and Girls Clubs out there, and Brian got on the call and he really talked about how to set up a Boys and Girls Club, what the process is, and gave really good information to all the participants. And the participants on the calls weren't necessarily healthcare providers. They came from tribal programs. They came from other federal agencies. There were a lot of nonprofits that were on a call, and folks just started getting interested in male health, native male health. The second webinar, oh, sorry, the another presenter on that youth call, and this was all geared towards youth, was Keola Chan out of the Ahakani Foundation in Honolulu. And they have this really cool traditional program where they take their young men or boys, and they put them through a sort of rite of passage. And it was just amazing. They have this professionally produced video, and they have this entire program. They have conferences, and I wanted to go, but the federal government wouldn't let me go to Hawaii. So, but I'm going to go someday. It's just an amazing program. They get back to their traditions. They get back everything from nutrition to mental health to spirituality and how to be a good man. That's basically the upshot of all this. How to be a good father, how to be a good husband, how to treat people with respect, treat yourself with respect. And, unfortunately, I don't think that happens enough in our society. Young boys don't have those role models. So he was also on. We had some directors of our youth regional treatment centers, and our the Indian Health Service runs 10 youth regional treatment centers, which offer holistic approaches to youth in trouble. So if they're having alcohol, substance abuse issues, and they get in trouble, well, they can go to residential treatment. But a lot of the YRTCs are incorporating mental health services. They're also incorporating spirituality and cultural based activities, and uh, and they did a presentation. It was just really well received, and it was a lot of really good information. And Aaron Bailey, who heads up the Aspen Institute's Center for Native American Health, also presented, and they're doing some wonderful things at the national level. So, so it's kind of like bringing the national level together with the community level, and we're just trying to figure out how we can get things done. Oops. So the third webinar, um, after many months of trying to track down Billy Mills, I did finally track him down. Of course, like any man, I had to get in touch with his wife, who who helped me corner him, and he finally agreed to do a webinar. And he did an amazing webinar. It was a full hour and a half, and he talked about some of those same things, his experiences. I mean, everything from being an Olympic gold medalist in 1964 to his kids and his grandkids, and um, having arguments with his wife and how to resolve that. And it was just a really nice conversation with Billy, and we're really grateful that he agreed to do that. And yeah, well, Gaza. And the last webinar was most recent, and we did a focus on fatherhood. And we had Clayton Small, who runs Native Pride, and we had Al Pooley, who talked about um, his work with the Native American Fatherhood and Families Association, which is another really outstanding program. He's a social worker. He's been married for 45 years. He has kids, grandkids, and when he speaks, he speaks the truth. And you hear him talk about what, especially younger men hear a man like that talk about what uh, male health is all about. You tend to listen. So we've done something, you know. We can't do a lot. We don't have a budget, but Native male health is important, and we always were always reaching out for partners. Um, I think most recently NIH has participated, so we'll be looking out for more participation in the future. Hint, hint. I just wanted to provide more information, and we can make this slide set available. But Billy Mills and the Running Strong for American Indian Youth, the website is up there. Clayton Small's website and Al Pooley's website is up. And Brian Yazzie, Keola Chan, our YRTCs, and Aaron Bailey's Center for Native American Health. So if you're interested, there are those websites to go and visit. So um, when we were having these discussions, I came up with some potential goals. When you're thinking about this, it's like, okay, we have a lot of males, native males, that are dying for a wide variety of causes at younger and younger ages, and we're having years of potential life lost. Um, and that doesn't just affect the males, right? It affects their moms. It affects families. It affects parents, grandparents, aunts and uncles. Um, it's a huge problem, and it's. I think it also relates to all the other issues that we see in the community. So we have to address native male health. So I just sketched out like a couple of slides, and we were at a meeting one time, and you know how it is. I just pulled out a scratch piece of paper and I kind of put these things up. So these are in no way intended to be policy statements or strategic objectives, or you can't hold me to it, in other words. But a few of the things that I thought of was, we need to identify and develop promising practices and other resources to promote Native men's health. Nobody knows what's going on. Um, so maybe if we can get some best practices, like some of the ones that we highlighted in the webinar series, make that available to other communities, other programs that want to get these things started. And they obviously do, because I've gotten a lot of feedback on it. And a lot of people have reached out and said, hey, how can we do this stuff? And so I'm really pleased with the feedback. Um, I wanted to identify some potential collaborations and strengthen Native male health programs and services. And we've done that. The Men's Health Network has been a great partner, and that's been Jimmy Boyd and Anna Fadic. They've been really great to work with, and they do the press releases for us. They help us put things together for the webinars, and it's hosted on IHS websites. So um, we've also had great participation from folks who aren't getting paid to do this. They do it because they see it as an issue, and they step forward and they donate their time to help develop the webinars and help coordinate. So and those actually include retired public health service officers and retired IHS employees. So Rick Bothwell, Olivia Casey, Leo Nolan, and we also have Sal Giorgiani he heads up the Men's Health Caucus for APHA, for the American Public Health Association. So we've got some really good partners, and we're really happy to be working on this. So some of the other ideas, just beyond those initial first steps, identifying some practices, looking for collaborations. I think it's really important that we create a clearinghouse on the ihs.gov website that lists the best and promising practices so people can get access to them. I mean, right now we're just piloting this webinar. When we're picking up a few of the programs out there that are doing this work, and we're sharing that with folks in the field and our federal partners and other interested people. But we eventually want to get that up on the website so that people can access it and really if there's a curriculum developed, they can download the curriculum and they can use it. It was funny, after the last webinar I got a call from our IT department, and they offered to build a website for me. I mean, how many times does that happen, right? Your IT calls and says, hey, we'll build a website for you. And I was like, sure. So yeah, that's the third step we're working on, to build a website. Some of the other things that need to be done down the road. Access to care for Native males. I mean, we don't go see our healthcare providers, right? It's like one of the last things we do. We could have this real serious issue and just, nah, it'll go away. If it's still there in a month, I'll go see my doctor. So one of the things we need to do too is not educate males about their health, but educate their wives and the women in their lives about their health, so that they actually go get checked out and get care. Making clinical care more accessible, but also culturally relevant. We've heard a lot about cultural competence and cultural relevance of services, but there's also a whole culture with men. Health education with men is a lot different than with women. So that's one of the things we're kind of thinking about. And is there a way that we can develop a way for healthcare providers to talk to men in a way that's meaningful and in a way that's effective? One of the other things too, we need to think about, incorporating male health into strategy. So when we're thinking about maternal and child health, we also should be thinking about male health too, and addressing things holistically and from different angles to try to get at the uh, the health of the family and the health of the community. We need to improve the quality of care for Native males through, again, training the providers on communications, but also culturally tailoring that to Native males. And a lot of times, what gets Native men in the door is the sweat lodge, right, or the ceremonies, or some of the more culturally based things that people often refer to as complementary or alternative medicine, which I think a lot of males see that as their primary choice of medical care and not a complementary or alternative uh, choice. But that can also, when you bring men in for those services, they also tend to access primary care services at higher rates, and so that's kind of like a different approach. We need to be thinking about that and working on that. The other thing we noticed is that there are no formal evaluations of Native male health interventions. So although we've identified some really good, promising programs out there, promising practices, there hasn't been any formal evaluation. And that would be something that we could work on. And of course, more research. And research identifying not just risk factors, but I think we've heard a lot today about resilience and protective factors, strength-based factors, which I would argue that are equally, if not more effective than reducing risk factors. If we can raise the protective factors, that can also work to prevent poor health and disease. So that's it. I'm out of time. And again, I thank you so much. Thank you.